questions and discussions, because this is what makes a meeting like that so interesting. So George assigned me this last lecture. I'm not really sure how to feel about that, because it's a real hard challenge for me after all these excellent talks. Thank you. Especially from fields that are not my field, like Jerry's talk right now, to kind of wrap up a little bit on the one hand, and on the other hand to kind of try to cover things that we are doing in daily life. And you're going to find out that we still have a lot of open questions. So my challenge is now to discuss with you some special aspects of resuscitation. And I'd like to outline a little bit what I'm trying to focus. The question is on positive pressure ventilation devices in the delivery room. I only very briefly will touch ventilation. We have heard a lot about ventilation already. And chest compression, medication, and finally some practical aspects of meconium stain or meconium aspiration syndrome. Now, while preparing this talk, I was quite surprised to again find out that for most of these topics, we are still in the phase of developing the right way to go. And most of the recommendations are basically grounded or derived from experience and observations. So how about positive pressure ventilation devices? Those are the different devices you use in your delivery room suite, which would be the self-inflating bag right here, attached to a flow source where you can determine the flow, and you have probably a blender attached to that if you need it. If you're well equipped, you'll have a pressure monitor in order to know how much pressure you apply to your infants. This is the flow inflating bag with a oxygen source attached to it. Who is using flow inflative bags in the delivery room? Probably nobody does anymore. Most of you probably use the self-inflating bag. I do. So another possibility is the T-piece pressure source, which is increasingly getting to be used now in different delivery rooms, and we actually have it in every single room now available. But you may also have a simple ventilator to be used as a pressure source. And when you look into the literature, in order to find out which of these devices is actually the best one, there's again very little literature. And we have to go back to Melbourne again to see what is actually done with regard to positive pressure devices. And Jennifer Dawson from Peter's group looked into the efficacy of both the T-piece resuscitator and the self-inflating bag with regard to oxygenation, saturation throughout time. And you can see that there is not much of a difference with these two devices as you compare them. So you may use both of those, and you just have to be aware which one you're using. We talked a lot about the appropriate FiO2, and I'm only briefly gonna scratch that again, and the appropriate positive pressure maneuver. With regard to FiO2, we heard that already, and this is only an additional summary of the data out there. This is the combination of the available meta-analysis put together, and you can see that there is a fair amount of patients enrolled in a number of studies. Finally, coming to the conclusion, we heard that already, room air in term neonates is advocated right now, but we still are unsure about the use of oxygen for preterm infants. We heard about that as well. And I only want to very briefly point out some data we've been confronted with regard to oxygen in preterm infants. This came up actually by the support trial initially, where the observation was that over time, and this is not delivery room, of course, but it's long-term oxygen saturation, that infants in a higher target saturation area between 91 and 95 did a little better than those in a lower target range of oxygen. And over time, this issue has been addressed by a number of different studies, not coming to a final conclusion, but showing that in preterm infants, possibly a rather higher saturation target range might be beneficial with regard to overall survival. So we have to watch very carefully what future data are going to provide us with regard to the application of oxygen in preterm infants. So I'd like to briefly wrap up what we heard already. We want to start resuscitation with positive pressure ventilation in term infants with room air. Adjust that as we've seen that from Peter already. And start resuscitation in preterm infants probably at low FiO2 and titrate according to the normal values we have now. Now, we heard already about sustained inflation, and again, this is a repetition of what we heard before. What is the appropriate positive pressure maneuver? You've seen this study by Ariane Tepas as one of those who investigated the sustained inflation over 10 seconds, and we discussed already the pitfalls of this study, so I'm not going to go there too far. But I'd like to show you also some rather older data in animals where sustained inflation was explored. And what they did here is they applied sustained inflation in the first hours of life in a piglet model, where they compared different amounts of sustained inflation, which were, of course, rather high. But what then they were able to demonstrate is that high sustained inflations might also result in an impairment of lung mechanics. So what's the appropriate maneuver? We don't know yet, and we have to wait for further data. There's one randomized controlled trial with, again, only a small number of infants enrolled that was not able to show any benefit of sustained inflation with regard to major outcomes. So to repeat again what we heard before, we'd like to have a pressure monitor while we apply resuscitation in the delivery room, and the best thing would be to have tidal volume readings during resuscitation to avoid overinflation, and we have to look for new data with regard to sustained inflation. So far, I'm repeating data you've seen. Now we come to chest compression. And if you look into the evidence with regard to what's the best way to apply chest compression, data are even more scarce than in other fields. So what about the rate? You all know about the suggestions in the ILCOR and ERC guidelines that the appropriate rate of chest compression should be 5 to 1 in the neonate with the rate of 5 compressions to 1 chest inflation. And just recently, the group of Hemway and co-workers in New York did a mannequin study where they investigated basically the different rates that have been under discussion over the last years. And it turns out that, in fact, the 3 to 1 ratio as compared to 15:2 to 5:1, or the 5:1 to 15:2, turns out that 3:1 is the best with regard to the depth of compression. This is about 1 millimeter more as compared to the others. It is the best with regard to the number of compressions you are able to achieve over the period of 2 minutes of resuscitation. So you have 37 compressions more you achieve as compared to 15/2. And the number of ventilations you apply in the resuscitation of neonates is also higher. So the IPOKRA recommendations have a little bit of evidence now from mannequin studies that are derived from these numbers. How about the way of compressing the chest? As you know, there are different possibilities. Either use the two-thumb technique that is outlined here as compared to the two-finger technique where you compress the chest with two fingers from above. And you all know that the technique of this two-thumb compression actually aims to continuously have a cardiac output. And if you look into studies comparing these two methods, then again there are only mannequin studies available that compared the possibility of achieving the correct position with these two ways of compressing the chest to correct the position in preterm infants, the correct position in preterm infants as well as in term infants. And for all these applications, the two-finger method is much less convenient or much less appropriate to achieve the right position during chest compression. So the suggestions in the guidelines are supported by these findings to use 3:1 in a 90 per minute compression rate, and then to alternate that with about 30 ventilations per minute, resulting finally in 120 actions per minute during neonatal resuscitation. Now I'd like to discuss a little bit with you some resuscitation issues concerning medication. And again, we don't really know what's the right way to go. And if you look into resuscitation protocols, luckily only 1 in 1,000 neonates that need resuscitation actually proceed to require medication of any kind. So that's the good news. So the question is, what types of medications are actually evidence-based? And basically what we have to admit is that what we are doing with regard to medication is mainly extrapolated from adult studies, and we don't have nice randomized trials looking into either dosage or looking into different types of medications we are using. So I can't give you data on epinephrine as it is suggested in the guidelines with a 0.01 to 0.03 micrograms per kilogram intravenously, and I'd like to discuss with you a little bit about other medications which are now not more than bicarbonate and fluids. Now, if we look into bicarbonate, I'd like you to have a look in one publication by Judy Eschner in 2008, where she was questioning the use of bicarbonate in a neonatal unit as well as during resuscitation of neonates at all. The reason of questioning the use of bicarbonate, who is using bicarbonate in his unit eventually? Some people do. Who is using bicarbonate in a severely asphyxiated infant, let's say with a pH of 6.9? Some people would do. Who would not do that? Okay, so what I'd like to do now is to discuss with you a little bit about the physiology regarding the application of bicarbonate. As you all know, bicarbonate excuse me, is in equilibration according to the Henderson-Hasselbalch equation or the carbon metabolism and reacting with hydrogen ions. It is reacting to dihydrogen carbonate, which is then dissociating into water and CO2. So basically that's ground physiology, and usually during our metabolism we are eliminating CO2 into ventilation. However, if we have a situation during resuscitation where ventilation is impaired, this possibility to eliminate CO2 is also impaired. So what happens with a cell if CO2 accumulates within the organism or within our body during a situation like that? Then CO2, which is very prone to cross membranes, will easily enter the cell, accumulate in the cell, and finally lead to a acidification of the cytosol. Because the same equation holds true within the cell, these cells are now facing higher concentrations of protons and potentially will develop cell damage. And actually there are a few studies focusing on the effect of bicarbonate after hypoxic ischemic insult. And this is an animal model in piglets again, where hypoxic ischemic insult has been induced, and the animals have been resuscitated either with normal saline or with sodium bicarbonate. And what is shown here is the carotid artery flow during resuscitation. And as you can see, this had very little effect on the carotid artery flow over the time of 4 hours. If anything, after these 4 hours, the flow was least in the bicarbonate, or was low in the bicarbonate group. However, when they looked into the metabolic response of these animals after bicarbonate resuscitation, after reoxygenation, the animals that received bicarbonate had a markedly reduced capacity to handle radical oxygen species with an impairment of the superoxide dismutase activity. So what we can learn from that is that we have to be quite cautious in using bicarbonate. In addition, data have supported the observation that bicarbonate increases the rate of intracranial hemorrhage in preterm infants if you apply it, probably due to the high osmolarity and the change of intravascular fluids thereafter. The next drug I'd like to discuss with you is normal saline. This is something we routinely give to our babies, either if they are hypotensive in the delivery room during resuscitation, or if we feel that somehow these infants are volume depleted. And over the last couple of years, normal saline has been part of a debate in whether or not this is the right approach. When we look into water, you all know that water is a molecule that is constituted of two hydrogen atoms that are connected over covalent bonds to oxygen. If we now add salt into this water solution, these covalent bonds between hydrogen and oxygen are weakened by these two strong ions, sodium and chloride. So as a result of that, if you add more of this saline, more of these species of protons increase in your solution. And as a result, you can actually measure the decrease of pH as a result of putting salt into water. Now, is this clinically relevant? If so, we should be able to measure that. Because if we decrease the pH, we will increase the concentration of protons and then finally result in acidosis. And there are very few data regarding the effect of saline substitution or application in neonates, and we have to go back into the adult literature to see that, in fact, the application of normal saline in otherwise healthy individuals that were, these were 24 patients that underwent a prospectively elective gynecological operation, so there was no real problem in these patients whatsoever. And these patients then subsequently over time were given either ringalactate as a volume substitute or normal saline. And what you can see here is that in fact after normal saline infusion, the pH in these patients dramatically decreased over time, indicating that in fact normal saline might induce metabolic acidosis in patients. This is kind of the quintessence of a quite complicated approach that was founded by Stewart and co-workers for the acid-base regulation in humans. Now, I'd like to conclude from here to summarize what's available on medication. Epinephrine still is the first-line medication during resuscitation, but still we might need some more data with regard to the actual doses we need, especially in preterm infants. If you use bicarbonate, you should use it very cautiously. Of course, bicarbonate is able to normalize our values in the blood gas analysis. However, what it does in the cellular and subcellular level is controversial, and you should be cautious. Normal saline as volume bolus, although it is recommended in guidelines, should also be used cautiously, and you should be aware that it may induce acidosis. But as we said now, over the couple of days, very often more data are needed. So do you have any questions until I proceed so far? Yes. Just a second.
How to treat hypotension, which is caused by hypovolemia?
That's an excellent question, of course. It depends very much on the cause of your hypovolemia. If you have a white asphyxiated infant where you're not sure whether or not this infant actually experienced blood loss during the delivery, either prenatally, antenatally, or perinatally, then probably the best volume to give there is blood.
Yes, I would like to concern about the resuscitation period of time. So it will be hard to have a blood to transfer during a resuscitation, yeah?
Well, no. Why? Because we talked about venous access and
But we still have only 10 minutes to do that.
Right. Okay. That's right. I mean, fluid resuscitation in an asphyxiated infant has to be done very cautiously as well, because even if the baby is not volume depleted, it might be in a situation where it's highly acidotic and the heart function is impaired due to the asphyxia. And if you add volume to a situation like that, this infant might even be worse because it's not going to be able to cope with this additional volume load.
Yeah, definitely. But what about the preemie and some abruption of the placenta?
Of placental abruption and
Preemie baby.
suspected fetal blood loss. Of course, in an emergency situation, you probably don't have immediately blood available. Although I think nowadays in a modern delivery room, you should have packed red cells with seronegative blood available. We do.
Do you have?
Yes, absolutely. We have it right in the resuscitation area, and it's a matter of minutes to have that available. And we do that. Probably.
If I have to choose between normal saline or glucose or lactate or ringer lactate, what do you prefer?
There are no data in neonates regarding ringer lactate, as far as I know. I didn't see anything. Peter, are you aware of any? But from I mean, you have to be aware that lactate by itself also acts as a strong ion. So eventually, the effect of lactate is not much better than the effect of sodium chloride. There are some discussions going on now also using plasma expander, like they do in the adult world, but there are no data available for patients yet. Yes.
Blueberry, you are sleeping. The microphone is...
Blueberry sleeping.
Thank you. Let's make it simple. What do you use in your unit as a volume infusion in your unit, if you decide to do so? Not in the resuscitation.
In the neonatal unit?
Yeah, for a preterm infant, if you decide that he or she needs volume.
Right. So if you, the reason for your volume depletion is water loss, which happens a lot in extremely low gestational age infants, then of course you have to replace that. And you do that by increasing total volume intake per day in your TPN then.
But if you have to do it in 1 or 2 hours?
Then you have to actually, from my point of view, look into your child whether or not they're, because then it's an acute situation. You have to rule out what's the reason for your hypotension. Is it a low cardiac function, for example? Then you can easily see that on ultrasound. Or is it volume depletion? You also can see it on the filling of your heart. And if you don't have blood available, that would be probably the first thing to do. With regard to blood, there are now also increasing data supporting late clamping as kind of a volume recruitment for infants at birth. And more data are coming out there, probably making volume resuscitation less likely in the future. Yeah.
I just wonder if you're asking about the the preterm baby whose blood pressure starts to drop in the first couple of hours of life, and then everybody says you must give this baby normal saline, 2 normal saline boluses, and then start dopamine. Is that what they do in your
Yes,
unit?
exactly.
Okay. So I think yes, we're not talking about the really action-packed thing. This is normal preterm baby behaviour. Okay, so my approach, and I'd be interested in hearing Andreas as well, is that if the baby is not acidotic, if the baby's doesn't have a low bicarbonate, the lactate is not bad. And so we think that no matter what the number of the blood pressure is, the baby's vital organs are being perfused. Wait and see, because most times that blood pressure will slowly drift up, and so it might, you've got your 26-weeker and the blood pressure, the mean blood pressure drops to 23 or 22, and that's when you start getting nervous, right?
Yes.
Yeah. Okay, so
I know what you're talking about, but my question refers to the kind of fluid. Do you replace the normal saline by something else?
First, be patient, and if the baby is got a normal pH, then it will most likely come up. Okay, so you've nailed me to the wall. What am I going to use? I'm going to use normal saline, 10 mils per kilo, and I might give a second round if the baby is, particularly if the baby's acidotic.
Thank you very much. I had a second question. Do you use a bicarbonate infusion in your unit for metabolic acidosis?
Yes. So there are certain circumstances, especially if you have very immature infants that are probably losing bicarbonate through the kidneys, where bicarbonate substitution is probably still a way to go. But then you would use it very cautiously over a long period of time, dilute it and all that stuff. Other than that, in rapid correction of metabolic acidosis without renal loss, I would not recommend to give bicarbonate, especially not in an asphyxiated infant, because there are quite substantial data supporting that bicarbonate after asphyxia is rather decremental. Okay, if there are no further questions on that issue, we can... Oh, no, there's one. Oh, good.
I'm really sorry about that.
No. That's excellent.
The last one, I would like to know how to monitor tidal volume during the resuscitation, because you mentioned about that. Well, how to monitor tidal volume?
So this is actually a question for Peter, and you know that Ariane Tepas and the guys from Melbourne are about to develop this respiratory function monitor for the delivery room. We just heard that this got stuck a little bit. What we actually do in the delivery room is we have full-scale ventilators there with pneumotacs where we can actually measure over a nasopharyngeal tube tidal volumes or when the baby is intubated. Yeah. Okay. No more questions. I can proceed, or... Are you still awake? No. Anyway, now I'd like to kind of scratch on the last topic I've been given by George concerning a clinical problem we are eventually facing. And I'd like to start again with a case. It's a 41 plus 1 weeker that was delivered in an outside hospital due to a silent cardiotochogram. The initial APGAR was 346, pH was reasonably low, heart rate as well, got CPR, surfactant, and received high-frequency oscillation with a mean airway pressure of 19 and 100% oxygen. So this baby was really sick. What's your diagnosis? Any suggestions? Aspiration, exactly. So the baby was born from thick green meconium stained amniotic fluid and subsequently developed severe pulmonary hypertension of the newborn. It needed high frequency oscillation at higher values, still mean airway pressure of 16, inhaled nitric, again surfactant, but PO2 was still low and CO2 increased. So finally, the baby was transferred and put on ECMO and needed ECMO in order to treat meconium aspiration syndrome. So I'd like to talk a little bit about meconium aspiration syndrome, which is luckily a rather rare disease. However, in meconium aspiration syndrome, still 4 to 12% of these infants would die from the disease. A few of them only need oxygen and no further therapy. However, they are very prone to develop pneumothoraces. A lot of these infants need respiratory support, with about half of them needing intubation, then going into either pulmonary hypertension or pneumothorax. So the question is how to actually treat meconium aspiration syndrome. And that leads us to the question which we already have kind of scratched during the last days. Is it necessary to suction an infant born from meconium-stained amniotic fluid? And the resuscitation guidelines in the new version elaborated on that, predominantly due to a big study that has been done or has been published in 2004, you all are familiar with. But the interesting thing about that is that it started out with a huge number of patients, finally having more than 1,200 infants in the either suctioning arm or non-suctioning arm. And I'd like to go through the results of this study with you briefly. This study actually showed that out of these 1,200 infants, if they were born from thick meconium-stained amniotic fluid, which was 13% of these infants, and you are aware of the fact that up to 30% of infants are born from more or less meconium-stained amniotic fluid, then 13% of those are born from thick meconium-stained amniotic fluid. And as you can see here, the incidence of meconium aspiration syndrome, the need of mechanical ventilation, and the mortality of meconium aspiration syndrome was not affected whether or not these infants were initially vigorously suctioned or not. The same holds true for infants who were born by cesarean section. Again, no significant difference with regard to the outcomes meconium aspiration syndrome, need for mechanical ventilation, whether or not there was labor prior to the C-section or not. So these data finally led to the recommendations in the ILCA guidelines as well as in the ERC guidelines that in a vital, actively breathing infant, the suction should not be done routinely and only should be limited to the flaccid non-vital infant born from a thick meconium-stained amniotic fluid with this special meconium adapter. You should be careful with bag and mask in these infants, and oxygen should be applied if the SATs are not increasing in room air above 85%. So what else could we do in an infant after meconium aspiration and the development of meconium aspiration syndrome? And rather old data suggested that surfactant treatment might be a good option based on the observation from animal data that meconium not only is occluding the small airways, but is also inducing an inflammatory response in the lung, resulting in surfactant inactivation. And therefore, in 2007, relating to 2 studies that were available so far, the recommendation of the Cochrane review was that surfactant treatment, most likely in higher doses as we used to use that in RDS infants, is recommended for the treatment of meconium aspiration syndrome in order to prevent the need for ECMO. So, however, there was no difference with regard to death or chronic lung disease in these infants, no matter whether they used surfactant or not. So, several other approaches have been discussed, and thanks to our audience, we already mentioned that before, meconium aspiration syndrome treatment with surfactant lavage. And so this is not the Cochrane library, this is Mr. Cochrane, who did animal studies in a meconium aspiration syndrome model where he applied a surfactant normal saline mixture into animals that were previously injected meconium into the lungs, and showed nicely that the meconium lavage was able to reconstitute lung function with regard to gas exchange as compared to those animals that did not receive this lavage. Now, is that feasible for our patients? And in recent time, actually, there were a number of studies investigating the applicability of meconium lavage in infants with meconium aspiration syndrome. And in 2011, a systematic review, and you have seen a lot of those now over the last days, has been published, putting together most of these data available, with just two of them being in the rather more recent area, especially the study by Peter Dargaville from New Zealand. And the conclusion from this meta-analysis was that overall treatment of meconium aspiration syndrome with a surfactant lavage procedure might reduce the need for ECMO or death in these infants substantially. However, the problem is that there was quite some heterogeneity in the studies, with quite different preparations of surfactant in saline, with different amounts of fluid instilled in the lung, and different frequencies as these procedures have been undertaken. Who has used surfactant lavage in a meconium aspiration syndrome infant, or who has experience with that? It's not a pleasant procedure, isn't it? The infants do not so well while you instill large amounts of fluid with surfactant into these babies. So it's quite challenging. Do you do that in Melbourne?
It scares the life out of me.
Me too. But it supposedly works. However, we would also rather apply surfactant repetitively in these infants, as we are used as neonatologists. Now, nevertheless, meconium aspiration syndrome is a severe disease. However, if you combine the possible therapies that you can apply to these infants, both ECMO and high-frequency oscillation and others, these infants have the best prognosis in a population of ECMO patients in the neonatal field as compared to for example, infants with severe pneumonia or CDH. What you can see here is the number of patients treated in the ELSO registry, which is the extracorporeal life-sustaining therapy registry, where most centers that do ECMO on a regular basis put their data in. And on the left side, you can see the columns of number of patients that are in the database. And on the right side, you can see the survival of these patients. And here are the infants with meconium aspiration syndrome that have a rather good survival once they need ECMO, because this is a disease that is healing pretty nicely if you don't destroy the lung during mechanical ventilation. So this is pretty much what I'd like to add on what we had before. This is the baby after meconium aspiration syndrome, now doing well. And of course, at the end of this talk, I'd like to show you our hospital as well. And you're very welcome to visit us there at the 10th floor up here, where we can, on the one hand, face the center of Munich, and on the other hand, look into the mountains. And this is our transport system, which is very close to the hospital. So feel free to come. And I'd like, again, thank you for your patience, for your participation. And I'd like to thank also the other colleagues that gave talks here, because I learned a lot again. And for someone talking here, this is probably also one of the exciting things, to meet people from other fields. Thank you very much. Questions? You're done. You're ready for lunch, is that right? Okay, that's fair enough.
So thank you very much for choosing this seminar. Thank you for choosing Krakow. We have great lectures. We have great audience. Have a safe way to back to home. Thank you very much.